So our next presenter is Dr. Ahmed El-Boré, and they're presenting on All Roads Lead to Rome.
Okay, thank you. Good morning, everyone. Once said that all roads lead to Rome, and today we will discover one of these routes. Our patient is a 57-year-old lady, status post mitral valve replacement twice. Last one is on top of severe paravalvular leak. Presenting to us with shortness of breath at moderate exertion and severe hemolysis that necessitating repeated blood transfusion. Here is her echocardiogram, showed dilated LV dimension with preserved function, hugely dilated left atrium with significant mitral paravalvular leak at the anterolateral side at almost 10 o'clock. So, what you doing here in the coronary session, we'll discover together. Actually, this patient has challenging transseptal puncture. We opted for a higher posterior one to be more aligned with the anterolateral defect. But the puncture is challenging even with TE guidance. So we did something off-label. We used it before in some cases, which is doing the transseptal puncture using a CP12 CTO wire. And here is all thing started. The wire take a funny course, so we opted for transseptal needle injection, and here is what we got. Oh my God. It took us about few seconds to recognize what we are dealing with. We have some sort of fistulous communication through the septum into the left main coronary artery. And what we see on the right side is almost a hematoma or a false lumen in the left main and compressing almost the LAD. So, surgeon was notified at this time, and we have already their femoral axis used for snaring the retrograde for the BVL closure procedure. So we introduced GL for guiding caster, and then passed a cyan blue wire into the LAD and circumflex. And then we did IVUS imaging, which showed a very large intramural hematoma compressing the lumen of the LAD and also compressing the lumen of the left main. So we decided upon this picture to do PCI to left main LAD to decompress this hematoma. This was done using a 4O stent, followed by both using a 5O stent. We used a guideliner for injection to minimize the inadvertent flow into the false lumen during adjusting the stent. At this moment, we have a discussion with the surgeon, should we stop at this moment or we can proceed. The patient was hemodynamically stable, no pericardial effusion, so we thought that we mostly went through a transection in the septum rather than perforating the atrium itself. So this time we did the puncture using steerable sheath, Agilis 1, and it went successfully. Then closure the defect using AVP3 device 10x5, and there is the final result. Will seal the defect with no residual BVL, and fortunately the patient is discharged home safely after 48 hours. So learning points from this case: imaging TE or ICE is progressively becoming the standard of care for transseptal puncture. Electrocautery or radiofrequency facilitated transseptal puncture in tough cases should be preferred rather than off-label solutions that we used in this case. And finally, coronary training is essential, even in structural program, to be able to deal with potential complication. And there is the title of our case, All Roads Lead to Rome, how this wire find its way to the left main, mostly transected the intra-atrial septum through the roof of the aorta, then into the left main roof. And there is thanks from our team at Aswan Heart Center. Thank you.
It's a brave case, and I'm even braver save, I guess. What did you guys, did you advance a microcatheter over this wire or the CP wire, or was it just
No,
the wire itself?
it was advanced through the transseptal needle lumen itself. But the behavior of this wire is totally unpredicted. So I don't advise, or we didn't did it again.
So the initial transeptal, you couldn't traverse or go through the septum with your regular needle?
Yes, it is almost keep sliding due to the huge left atrium. But at the second time, we used the steerable Achilles sheath. This facilitated our job, and it was a simple one. So if we back to a few moments before this catastrophe, we should do this from the start and not to use CP12.
I mean, just for most of us in the audience, can you go back to, can you take you back to the slide and just walk us through that angiographic anatomy, the injection through the transseptal needle?
Okay.
Yeah, I mean, as you're doing that, I agree. The CP12 is going to go somewhere. You know, a tapered, stiff, gram-weighted tip, and so I would, you know, obviously that contributed to this because it doesn't confirm you're in the right place. But I think when you have that gut feeling that it's not going the right place, you should always heed that emotional feeling like you did here.
So what we see here is fistulous communication between the left atrium septum itself. The track was intramural inside the wall of atrium, then through the wall of the aorta, ending by opening into the left main. What we see here is not the left main itself. It is mostly the large hematoma, and it finds a way or another into the circumflex. But the LED is not clearly visualized here because it was compressed almost totally by the hematoma.
I think it's very important too, your use of intracoronary imaging. Once you did get wires down, you're able to really nicely confirm your wire position in the true lumen before you did anything further, and to understand that hematoma presence for sure.
Understand, because when I searched for such a complication, this is the first time reported such complication.
I was just going to say that's a great picture of the pressurization of the intramural hematoma there. You can see that as the contrast darkens, that it's just filling that intramural space and compressing. That's a great picture.
Yes.
Not emotionally, though.
Well, then also on the IVUS run, if you go forward to that, you can see the dynamic compression of the coronary as well, which is horrific but great. So, you know, just to have that picture right next to one another. The initial puncture was with a standard needle, not an RF needle. The attempt that kept sliding was a standard needle, Brockenbrow?
Yes,
Okay.
we did it multiple times, but it keeps sliding. The patient has huge left atrium.
So do you think had you used RF, that would have been more successful, or